So I was asked to participate in the session on minimal residual disease. I was the third speaker. The first speaker talked about flow cytometry-based MRD testing. The second speaker talked about next generation sequencing-based molecular MRD assays. And I was asked to put all these things together, talk about the applications of it. So I went over a survey we have just conducted. It's not yet published, where we asked all the centers that treat patients with myeloma across the United States. And this was a follow-up on a study we did about 2 years ago. 2 years ago, we showed that around 30% of institutions that see patients with myeloma in the US do flow-based MRD testing. This time, we showed that 60% of centers do it. So that's an advancement. We also showed, unfortunately, that there is a lot of work that needs to be done, a lot of improvement. And that covers anything from how the MRD is done to how the samples are collected. So there is still about a 10-fold difference in terms of reporting out MRD status, the quantitative measures. I also, as part of my presentation, talked about where I see MRD testing is going. And I do think that MRD has now arrived in multiple myeloma, and this is a consequence of all the new therapies that we have available. Patients are really benefiting from these new drugs. They reach the complete response rate at rates we have never ever seen. It's very, very exciting. Survival is skyrocketing. It's beyond 10 years on average here in the US. So the way I see MRD is going from an application point is, number one, I think we already have the evidence, number one, that it's a predictor of outcome. Reaching MRD negativity is associated with longer progression-free and overall survival, and that is very supportive of the modern drugs. The second thing I talked about was how MRD will play an important role in the regulatory field for the approval and review and approval of new drugs. So as we get better and better drugs, the bar gets higher and higher. So if we are looking for overall survival or even progression-free survival, those studies will go on for a very long time, and or they will have to be very large in order to look for differences. So cost is going to be prohibiting the development of these new drugs unless we have surrogate endpoints. So MRD will be a necessary step moving forward, and the FDA is very well aware of this, and I talked about that. The last thing I talked about is how I see that MRD testing will probably become part of development of clinical trials. And I think we already are developing these trials. We are doing that, and I think other groups are doing that as well. So for example, if a patient is treated with combination therapy, reaching MRD negativity, can you stop the combination therapy? Can you go to maintenance? If a patient is treated with combination therapy and you reach MRD negativity, do you need to do an autologous stem cell transplant, or can you collect your cells and go right to maintenance? If you are treated and you are MRD negative for an extended period of time, and that needs to be defined how long that is, but could you even stop therapy? These are extremely interesting questions, and I think this is where the field is going, and it's going every 6 months. There is a new step forward, so it's very exciting.